Thank you so much, Hashem, for introducing me. And good evening, everyone. I hope that you are all doing great. It's my first time being between you today, and I'm so grateful and glad that Labika and Noura invited me today to present my PhD project that I have been working on in the last 4 to 5 years. And today is the first day of the month, which is my favorite month because it's first my birthday month. The second thing is the excited news that I completed my PhD last month, and I'll be celebrating my convocation in 3 weeks from now. So much, a lot of exciting things happening. Good. And it seems that you have a lovely community that I missed. So inshallah, you'll see my face more frequently. Okay, so let's dive into it. The presentation title today is A Syndemic Approach to Understanding and Exploring COVID-19 Vaccine Hesitancy Among University of Waterloo Students in Canada. Again, my name is Bara AlShurman, and you pronounced my name very correctly. I now hold a PhD degree in public health with a specialization in epidemiology and base statistics. I also hold a master's degree in public health and a bachelor's degree in dentistry. So one of the most striking findings out of my PhD project is that at the University of Waterloo, in one of the well-educated populations in Canada, 1 in every 3 students did not return back to take their COVID-19 booster doses. And that despite the fact that nearly every student took their primary doses. So this could be enough to say that education alone did not protect this group from being doubts about vaccinations. And that raised a bigger question, which is what does shape vaccine decisions once the pressure of mandate is gone? The initial response in Canada to COVID-19 vaccines was quite strong. Around 87% of Canadians received their COVID-19 primary doses. However, this percentage dropped to nearly only half of Canadians received their booster doses, and this percentage even dropped to 40% among those who aged 18 to 39. And that made me question why we're so willing to take their primary doses but not do booster doses. Is it just only because of vaccine mandate policy, or is it related to other factors such as a growing vaccine hesitancy over time? When we say vaccine hesitancy, it was defined by the Public Health Agency of Canada as intermediate position that lie on a continuum that range from full acceptance to full rejection. So people who are hesitant lie in the middle of this line. So they might accept some vaccines, refuse some, or delay others. Also, vaccine hesitancy is not static, which means that it changes as the context changes. For example, at the earlier stages of the pandemic, people were hesitant about the mRNA technology because it's a new technology, and they wondered how these kind of vaccines work. Later on, during the booster doses stage, they started questioning the necessity of these doses, and they started to change their risk perceptions. They started also to question the long-term side effect of taking COVID-19 vaccines regularly. And finally, they had a burnout of the long pandemic period and what they call it, the pandemic fatigue. So all these together comes to the fact that now we have 2 conditions in our hand. We have the COVID-19, the disease itself, which has amplified vaccine hesitancy by the misinformation, by conspiracy theories, and political polarization. On the other hand, we have the vaccine hesitancy, which was considered a social epidemic because it has an epidemic-like characteristics. Because vaccine hesitancy can spread through social contagion or peer influence. It can even clusters within communities in a way similar to an infectious disease. So my hypothesis here that we have 2 conditions that their interaction and existence together can create adverse health outcomes. And this brings me to the Syndemic, which was the main term that my thesis was built on. It has a theoretical framework, and the main idea is with this framework is that when we have two epidemics, the interaction of them in worsening adverse health outcomes is larger than the sum of their individual effects. Given this, I developed and published my framework, which was mainly to investigate how vaccine hesitancy as a health-related behavior interact with COVID-19, and both of them can result in increasing death rates, reducing vaccine coverage, for example, increasing hospitalization rate, and so on. So the main two objectives out of this project was first to identify the factors associated with COVID-19 vaccine hesitancy, and also to study how vaccine hesitancy changed from primary doses to booster doses. The second one is to assess the syndemic interaction between COVID-19 and vaccine hesitancy, and how both together impacted the uptake of booster doses. To achieve these objectives, I ran a cross-sectional study. I used a questionnaire, and this questionnaire was distributed online to both graduate and undergraduate University of Waterloo students in winter 2024. Once I collected the data, I got around 4,400 responses. And here are the main key findings from that data after I analyzed. So as you can see here, this percentage represents the delaying COVID-19 booster doses. So delaying COVID-19 booster doses among University of Waterloo students was nearly 3 times higher than delaying primary doses. Also, for refusing COVID-19 booster doses was nearly 5 times higher than delaying primary doses. When it comes to the hesitancy, the percentage of hesitant students toward booster doses was nearly double the percentage of hesitant students toward primary doses. When I asked a student about whether they took the primary versus booster doses, the first one, because obviously it was mandated, the primary doses, around 98% of students took their primary doses. However, only 66% of them received booster doses. And what is more concerning is that only 33.8% received their flu vaccine. Also, when I investigated and examined what are the factors that was associated with increasing vaccine hesitancy over time, I found that women were more hesitant than men. Also, I found those who were unlikely to follow governmental recommendations were more hesitant than those who followed government recommendations. Interestingly enough, I found that those who have no religious beliefs were less hesitant than those with religious beliefs. And also those who were not impacted by university mandates were less hesitant than those whose decisions were impacted by the mandates. This is what I studied about the interaction. So when I studied how vaccine hesitancy changed over time, or if it's increasing over time, I found that the largest increase in vaccine hesitancy over time was among those with younger ages, those who were not hospitalized due to COVID, those with low perceived risk of getting COVID, those who did not take flu vaccine or did not take meningococcal vaccine. And here are other interesting findings about the booster uptake. What are the factors or the risk factors that reduce the booster uptake? First, I found that increased vaccine hesitancy over time reduced booster uptake by 23%. Also, not following public health guidelines reduced booster uptake by 52%. and those who believes in conspiracy theories were less likely to take booster doses by 78%. So now what we can do with all these findings? I think we can come up with the multiple recommendations, especially for campus support to students. I believe that the students can benefit from having drop-in hours where they can ask their questions privately about vaccinations. And also we can have a vaccine ambassador program where student or trained student can talk confidently about vaccines with their peers. In this project, I used the scale or a measurement tool to measure vaccine hesitancy. And I believe that we can use this scale or measurement tool to measure vaccine hesitancy and flag early drops in vaccine confidence and act accordingly. And lastly, when it comes to promoting vaccinations or creating vaccine communications, universities should also engage students and take their opinion about this. One of the most central takeaways out of this project is that students are not homogeneous group, which means that when it comes to design communications about promotion, about vaccine promotion, we should address each of these groups' concerns. For example, if we want to talk with students who are hesitant about vaccines, I think we should stress on the fact that vaccinations are important for social benefits, for protecting your loved ones, senior professors, grandparents. But when we want to talk with vaccine-resistant group, those who are totally opposing vaccinations, I think we should stress on their personal benefits, and we should address their everyday concerns about short-term side effects or missing classes and how vaccinations are important to protect their own health. And lastly, for disengaged, those who just, they are just lazy to take vaccinations, I think they're gonna benefit from having personalized and well-timed reminders. So we can send them text messages, emails, and app notifications, and these kind of reminders would be sufficient to boost their vaccine uptake. Also, or lastly, the tone of our messages when it comes to promoting vaccinations matters as much as the content. Because if we look at the misinformation in social media, they are usually portrayed in a way that can be easy to remember and hard to forget. So in order to fight misinformation, we have to mimic this style by providing our students with real-life stories about the benefits of vaccines. Also, we can have or we can attach to these stories some kind of emotional resonance, so these stories can stick to students' mind and stay with them forever. We can also support our media or posts with visuals, videos, animations, or even peer-to-peer conversations to get the most helpful outcome of this. I think with that, my presentation comes to an end. Here is the list of references to those who are interested. Thank you so much for your listening, and now I can open the floor for your questions.
Fantastic presentation and beautiful visual. I was wondering, did you notice any concept of like booster fatigue? I know we're not to a point in COVID where there are like 4 or 5 different booster shots, and I'm wondering, was that something that played a role on whether people were more likely to take up the vaccine or not?
Yeah, of course. So I mentioned this in one of the slides where the students, especially younger ages, started to feel vaccination burnout of the regular communication. And I think that this was happened mainly because of the kind of communication that was not like attracting to students. This kind of miscommunication that resulted in the student that they became bored about vaccinations, and they started to ignore any message about vaccinations. So that's why I'm recommending to have a personalized messages, because when you send generalized emails about the benefits of the vaccinations, students gonna ignore them, especially they are at lower risk of developing complications of COVID given their younger ages. So they're gonna ignore these kind of general messages because they felt fatigue or burnout. And in order to address this, as I mentioned, our recommendations is to have a personalized messages and invite them personally to come and share their concerns about like taking COVID-19 vaccinations regularly. And given their age, we should give them transparent and honest recommendations, because the students also question, why should I take 5 doses? I am 20 and I don't, even if I got COVID, it's going to be flu-like symptoms. So we should address their concerns personally and in the private sessions. Is public answer your question? Any?
Okay, I was wondering about the term syndemic. Like, it's pretty like a new sort of word for me. So, are there, I don't know, is COVID, like, how do you combine those two together, or how does that eat? Yeah, like, if you could expand on that a little bit.
Yeah, that's a great question. So, like, if we wanna just go back to the, let's say, the foundational terms of these. So, first of all, like, we have the endemic. So, the endemic is something that happened, or the outbreak that happened within just a small region area, and like malaria in South Africa. So, it's consistently present in a small area. This is called endemic. And then the second one is the epidemic. So the epidemic is an outbreak that happen at a larger scale, like affect multiple countries. And if you remember the measles outbreak in North America, so this was considered an epidemic. So the pandemic is a wider one that affects globally, like COVID-19. But the syndemic is that when two epidemics happen together. Other examples for, like, there are some kind of articles who study the depression, and it doesn't have to be only diseases. It can be health-related behavior, like such as obesity, depression, maybe smoking. So when two epidemics happen together, how the existence of these two epidemics amplify and worsen the adverse health outcomes. So when you have one epidemic, like we saw in the COVID-19, like one pandemic alone, it's already exacerbating everything, like the financial burden, the misinformation, the political polarization, vaccine hesitancy as well. But also, if we add on top of that another epidemic, how this can also multiply and amplify the adverse health outcomes. And from that lens, they came with the word syndemic, that it's a next level to the pandemic. Thank you for your question. Yep.
Great presentation, first of all.
I was wondering if you looked at any studies that were focused on the vaccine uptake behaviors of like maybe an older demographic, and how that compares to student, and then the sort of messaging that's tailored towards both those demographics is not different.
Yeah, of course. So that's a great question. So the earlier stage that I started with is to develop my syndemic framework. So in order to validate a framework, you have to test it on multiple populations. So this is the first population that I tested my framework on. So my future plan is to apply this syndemic framework and test it to other populations, such as older adults. And the expected outcome, I'm pretty sure that it's going to be different than younger adults, because now I'm dealing in this project with a group that they are highly complacent. Highly complacent means that they are at lower risk of getting COVID-19. But what if I apply this framework on older adults or seniors who are at higher risk of getting COVID-19? Then maybe the initial answer would be the concerns of them going to be different. So students here, as you mentioned, they felt burnout or fatigue. As opposed to older adults, their main concern going to be about the side effects of taking vaccinations, because they already maybe immunocompromised, they already have multiple health conditions. So the main concern going to be about, if I take more than 3 to 4 vaccinations, how this going to affect my health. In fact, I already have multiple serious diseases. So it's gonna definitely show us different results. And I'm looking also forward to testing my framework on other populations. And the first one that came to my mind is the older adults, because it's going to show a totally different ripples. Thanks for the question.
I just offered. Thank you for the great presentation. I had like two-ish question. The first question I was wondering was within your population that you were interviewing, if there was any variation between groups. Because I imagine like a public health student probably has a very different take to vaccine hesitancy than someone, let's say in like clinical science.
Yes, exactly. So there was a question in the questionnaire, from which faculty are you in and from which department are you in. And I tried to run an association during the data analysis. There was no significant differences between students in multiple faculties and their vaccine hesitancy levels. That's why I did not highlight it here. Although I expected the same, that like faculty, like maybe engineering student gonna be more hesitant than those with health background, let's say. But there was no statistical differences here, and that the main reason why I did not include that in my results.
And then the second question I wanted to follow up with was like if you think the role of like disinformation or misinformation has like largely affected like the demographic that you're looking at.
Yeah, of course. I also asked them about the sorts of information that they rely on, and many of them were relying on social media, and especially like in this community, the peer influence, because like even you are convinced that the vaccine is the right decision for you, and your peers are not like taking it, so you're gonna be influenced by their opinion or their decisions as well. So when I ask them questions about what's the main reason that you did not take the booster doses, their answers were, I don't think that, or the most significant answer was, I don't see any priority in getting it, and I don't see any advantage in getting it, rather than highlighting the peer influence. Hope that answered your question. Yep, you have a question.
So it's Syndemic, essentially we're looking at the two epidemics, COVID-19 and vaccine hesitancy.
Yes.
I think, well, I don't know if you've explored this, but did you explore how one affects the other? Like, did you take that into account? I'm thinking for the Venn diagram that you have, where you had these two blobs and you're looking at the middle.
Yeah.
But did you see how if one of them changes size, then the other one will also change and how that works?
So that's a great question. So the main outcome from the analysis of this is that both of them reduce the uptake, or let's say reduce the vaccine coverage. But the next step is to okay, so maybe there's one thing that I did not highlight, is that I have to study multiple outcomes, like death rate or hospitalization rate. For my PhD project, I only focused on vaccine coverage, like how COVID-19 and vaccine hesitancy reduce the vaccine coverage. And yes, but that was presented in multiple figures, and my PhD project was a stats CV. So I excluded all these slides. Like it was 30 minutes presentation. So I tried to present my project in a lay language, and that's it. So I skipped multiple slides.
Thank you for presentation.
Yeah,
Have you explored any differences between hesitancy for the second dose versus third and subsequent doses? And like, as you take more doses, your likelihood of, say, getting a fever or getting sick the next day increases. So, and that might be a good deterrent from you taking like a subsequent booster shot. So how do you address this?
So you mean I tested the difference in vaccine hesitancy between a primary and booster. So primary mean first and second, and booster third or more. And obviously, the higher number of doses, the student were more hesitant about taking it, because like as you mentioned, either because they are afraid of getting the side effects of multiple vaccinations, or as she mentioned, like because of the pandemic fatigue, and also like I am at younger age, why should I take multiple vaccinations? I'm already protected or enough with taking only 2 doses.
Nice. And for people who may have taken a dose and they fell sick afterwards, are there any particular strategies in convincing them to like take subsequent shots?
Yeah, so I think so this is gonna be like more we did not like make practical recommendations, but the practical recommendations out of that is to discuss this closely, privately with a healthcare professional. So to let them know that when you get a fever, this is highly likely to happen to any vaccines, like even the childhood vaccines, like any kid or any children who have who get vaccinated, they're gonna get these kind of side effects. So it's kind of let's say intervention for reassurance, unless otherwise if they get high risk complications.